Today I'm here with Bill Cherniak, CEO at Rocket Doctor, and a Bridge to Health, and also an ER doctor up in our neighbors to the north in Canada. Thanks for coming on.
Yeah, thanks for having me.
And give me a little bit more background on Bridge to Health. Where'd this come from? What are you guys doing? Love to hear.
Yeah, cool. So we're a nonprofit. We're registered as a charity in Canada, as a 501(c)(3) in the US. And basically we partner with government, civil society, and academia to sort of think through and build healthcare for rural underserviced populations. And a little bit different than most NGOs in that we focus actually on comprehensive care. And so we do, clinical outreach where we actually send teams of docs, dentists, nurses, pharmacists, public health providers into the field to work with our partners. But, if we have 20 to 30 international folks, we'll have 75 to 100 local folks. And our team is embedded within the Ministry of Health, the local group. And then we do bedside teaching. So it's like a high intensity, education training program with formal, grand rounds every morning on different topics that are selected by our local team. And then we have a med ed lead that kind of builds that forward. And then we do infrastructure and research programs. So over the years, we've started initiatives into maternal health, ultrasound, point of care ultrasound, cervical cancer, diabetes, hypertension, and then oral health and preventative care. So, we're medical and dental.
Mm-hmm.
And our dental director, Tina, is a dental hygienist. She built this whole program for how to teach kids how to brush their teeth at schools, and then, engage in fluoride varnish to sort of protect their teeth for 6 months of the year, and then teach the teachers how to redo that 6 months later.
Okay. And do you have a team there the whole time, or is it intermittent, or how does that work?
So our model, again, is a little bit different in that we don't look at it as like the Bridge to Health medical dental program in Kenya. It's the Kisumu County government running their healthcare system, and Bridge to Health is coming in to support in different areas where the government thinks we can be helpful. So we actually probably shouldn't be there all year, because our goal is to come in and try to boost capacity with our partners, and then we leave, and it's the whole process, it's on them to kind of run their own system. And we're just coming in to, lend our thoughts and expertise and kind of turbocharge capacity a little bit when we have the big outreaches that come in.
Yep.
That makes sense.
Tell me a little bit how you feel around kind of the idea of medical missions. I know we had a huge amount of them for a period of time. Then there's been this entire swing back against them. Then there's kind of a swing of maybe we should be there in certain ways. Where do you fall in kind of that kind of spectrum?
Yeah, so I've actually been, over the years, I've gotten involved with a bunch of different groups on writing about medical missions and how to structure them. So the most recent project I've been working on is with a group called medicalservicetrip.com. And we actually, we did a eDelphi technique to survey, I think, 20 or so stakeholders from government, academia, civil society to say, what are the important components of a medical service trip? And we built this thing called the STAT tool that has 17, criteria, but kind of like 6 major areas that you can rank NGOs like Bridge to Health on, things like transparency, sustainability, cost effectiveness, local partnership. And actually we just submitted it. We just released a paper in Journal of International Public Health a couple weeks ago where we field tested that with groups in Latin America to actually see how that ranks. So there's like 300 NGOs that are ranked there now. So I think, to answer your question, like a paper a little while ago we worked on, we talked about the parachute technique, where groups kind of like drop in and then bring a suitcase of supplies and then work and then go home. So I think we probably all agree that model, while good intentioned, likely causes more harm than good. But there is certainly a way to work with local groups to build their capacity and come in short spurts that actually help them and doesn't cause harm, as long as it's kind of done carefully.
So by ranking them, is your hope that the local groups will say, hey, this one's highly ranked on this method, we'll take them? Or is it towards their donors? Or how do you picture that ranking making a difference in the world?
Yeah, well, I mean, first off, volunteers can choose to decide, like, oh, I don't really understand what their mission is, or, what they're trying to do here.
Yeah.
I don't know if I want to come with them, is the first. And then, at the end of the day, it's kind of like if some group from wherever tried to land in, like, I used to live in Baltimore for a bit, so tries to land in Baltimore and set up some medical group somewhere, the government's going to come down on them, and, they might get put in jail or something like that.
Yep.
So I think, appropriately, the government of Uganda over the last year actually banned a bunch of NGOs from working in the country, and is quite tightly regulating how they allow foreign groups to come in. So, Bridge to Health works with the sort of director of NGOs, as we're kind of building a new program in this place called Kalungala Islands on Lake Victoria that are sort of rural and underserviced. And that's kind of, so I would say it's really, I'm hopeful that the governments will take more control also in saying, this is our priority, this is where you can get involved, and kind of help to streamline that. So volunteers, governments, you mentioned donors. I think those are important as well, because if you're trying to decide where to open your pocketbook, you want to make sure it's going to the right place.
Yep. Do you picture that still for the foreseeable future, all the money for these type of organizations is going to come from donors, or is some of that money, do you think, starting to come from those local governments?
Yeah.
Because you're offering a service to the country itself, right? Or is that not a foreseeable thing for a while?
It's really hard. I had the, good luck to sort of get in touch with the Prime Minister of Uganda a couple of years ago, and had a chance to chat with him for actually quite a long time at his home in Kampala about, development, and hear his perspective on things. And if you sort of think about the challenges, I mean, there's all the kind of post-colonial things that go into the current ecosystem and financial resources of different countries these days. But if you look just purely at a GDP per capita basis, how much money does a country have per person? Like a country in sub-Saharan East Africa might be between $400 and $2,000 a month of income, versus the US, which is, I think, like $55,000, per year, I should say. So when you look at that, difference in income generation per person in the population, then you bring that up to the government level and difficulties in collecting taxes, and then you think about how most government healthcare systems around the world work on a public health funded model. And so if your population can't provide a big tax base, it becomes harder to kind of fund public health infrastructure. So I think for now, it's still, there is a lot of foreign assistance that I think can be done in a useful way to support. I mean, we're extrapolating in a big way right now, but
yep.
I think it's not going to go away in the immediate future, but models that are looking to try to be kind of sustainable, I think, are important.
Yeah, I've been thinking a lot about that in terms of the incentives that the NGOs have versus the incentives, say, a startup in Africa will have for providing similar services. Like, for instance, the drones and such that they've been doing with delivery and stuff like that are charging on each route that they do. And it's interesting to think about how those incentives may align more with the local government versus the incentive of a donor on the other side of the world. I'd love to hear a little bit about your guys' point-of-care ultrasound kind of work there. Because it's interesting to also think about bringing this kind of technology into that field and what their support can be around that.
Yeah, for sure. So we actually got started around maternal health, and that kind of plays also to our model, which is, ask the partners, like, what do you think is a big issue, and then how can we get involved? And so when we first started in rural Uganda, a big problem was that not enough women were coming to antenatal care during pregnancy. And so I was doing work in the emergency department in Canada, we have a course called Emergency Department Echo, the EDI course. So I was doing that, and then talked to one of the local Ugandan docs about these like cool devices that could be brought into the field. He's like, whoa, I didn't know that existed. That's like really good. If you could bring that into a village, it'd be too good to be true for a mom to get a free scan. So my kind of supervisor at the time, this guy, Mike Silverman, he was like, oh, let's do a randomized controlled trial and see if it works. And so we just put this together and offered ultrasound in some communities and didn't offer it in others. We gave everybody ultrasound at the end of the day, but we saw a 6 times increase when ultrasound was offered on the radio versus not, and moms coming out to get screening. And so then we started off there, and then we kind of built more of our ultrasound program out to actually do POCUS in the now current way that we think about it in our clinical outreaches, bringing devices to use at the bedside. And then we kind of built that out more, and then started to shift our focus towards pediatric pneumonia. And now we're actually kind of coming full circle back to maternal health a little bit. Yeah.
And do you feel like bringing that kind of technology, or what is it about bringing that technology that can be sustainable in terms of your guys' ranking and thinking about all that kind of stuff for them? Because I
So
can remember on many of the times I've been in Haiti and other places where it seems like every hospital had that like technology room that was like full of everything that was broken in the hospital, right?
yeah.
And their CT scanner would be in there and the x-ray machine and like 20 other technology things because they never had anybody who could fix anything. How do you feel about that in terms of the technology movement towards these places?
So I'll give you a prime example. When I was in Kenya in February, the clinical officers are kind of like a nurse practitioner, physician assistant equivalent of training in East Africa. So he brought me over to a room and said, "I want to show you something." And he pulled the curtain off of this like $20,000 ultrasound device and was like, "Yeah, we got this, donated by USAID a couple months ago, but no one knows how to use it, so it just kind of sits here."
Yeah.
Like, oh, so our big focus as an organization is on education and training, and we're trying to sort of, it's really hard to set this stuff up, but trying to figure out how to develop sustainable education that can be built off of a cloud-based tech platform so that you can provide remote mentorship to trainees throughout the year. Because let's say we do go over for just a short period of time, our partners are there all year long. Eventually the goal is to have local champions who will be expert trainers in their own capacity, but at least at the beginning, to have the ability to sort of get help from somebody. We can do that now with tech. And so we're trying to formally assess in different research studies how that works and if it's the same as in-person training, and kind of how to build that out.
Yeah, it's nice to think there might be some inflection point, especially last time I was in Uganda, everybody started to seem to have a smartphone to be able to like the capacity of those to bring in, an ultrasound tech to show them exactly how something works, or even the engineer to say, hey, just turn this a little bit and that's why your machine doesn't work. I could totally see how that could be beneficial. Now, some of your guys' work is back on our continent as well. Tell me a little bit about how you've bridged having both an international component and a relative domestic component as well.
Yeah, so that's where we get into the divide between the US and Canada. Bridge to Health USA, I launched with my co-founder Adam back in the spring of 2019. And our focus has always been on really domestic work. And so, like I was saying earlier, I lived in Baltimore and DC for a couple of years. Adam's from Baltimore originally. And so we focused our initial project on Baltimore. And then we built out a model that we're going to publish at some point, I think, around how other groups can maybe try and do this themselves. But starting from the top, doing a stakeholder analysis, looking at community health assessments from different health systems in the city, mapping out the like 300 NGOs and what areas they're all working in, looking at health indicators for different parts of the city based on zip code, and then kind of narrowing ourselves down into West Baltimore, and in particular focusing on 3 pillars. So oral health around dental care, and then partnering with local universities like University of Maryland and others, and then diabetes and hypertension, non-communicable diseases. But we're actually looking to integrate ultrasound into screening peripheral arterial disease, and then not creating. We love our vascular surgeon colleagues, but not just sending people out for endarterectomies, but linking them into primary care so they can get treatment for those chronic conditions. And then workforce development. So, trying to, as part of what we found in these community health assessments, was that 2 of the main things impacting healthcare were education and poverty. And so trying to create short-term employment opportunities for seniors in high school and perhaps freshmen and undergrad to work with our teams and be mentored. And then kind of the key that we're building out now is, finding the community partners to work with, folks who really think that we can be helpful. And we're looking at working with church groups in order to do that in West Baltimore, partner with them.
Yeah, it's nice. It's kind of that similar model where you go into the community and find those workers there and pull the community with them rather than top down. I like that. All right, so let's switch gears from this great work into your cold-blooded capitalism work as well.
Yeah.
So tell me a little bit about Rocket Doctor, where that came from and what you guys are doing.
Well, I will say that the cold-blooded capitalism, it comes a little bit from the NGO work, actually, because the whole thought process kind of started with this idea of, well, there's just not enough healthcare providers. There's got to be a way where you can get access to help and sort of training and care. And that then stemmed into this thought process of, well, I'm not going to charge people in East Africa, and hopefully we can develop something here in North America that we can then use to kind of be more sustainable. And so we've already actually started talking to groups, to nonprofits we could work with to help connect providers at least. So if a doc wants a consult from a low resource setting, we could easily plug them in. But Rocket Doctor's model is we're a telehealth company, but looking to do it in a more efficient and effective way by integrating at-home diagnostics and also developing clinical decision support systems to try to make the care more accurate and also kind of streamline the whole process for patients.
So what's it look like? Is it just a regular patient out there who has an urgent care problem, loads up your app and goes on like a FaceTime like model, or what's it look like for the end user?
Yeah, so we have, we're actually just about to launch in Canada this week and in the States probably next week, but it's a cloud-based system that's HIPAA, and the Canadian equivalent is Pipetta compliance. Regulations have been lifted with COVID, but our idea is let's just make sure that everything is as tightly regulated as it can be for privacy reasons. So it's a secured system that has both a telehealth component where you can do video conferencing and you can write your secure electronic health record at the same time. And that's what we have currently. And then building out all of those additional components to try to integrate them into the telehealth process. And kind of interesting, some of the work I'm doing right now actually is we're just going through ethics approval to use the Butterfly ultrasound that has this cloud-based kind of teleradiology system to get it into a patient's home. So COVID patients can scan their own chest. And syncing that with actual clinical care and having both blinded to one another, but seeing if there can be an impact in that way and kind of done safely. And that's kind of one example of tools that easily could be added in.
So do you picture with those kind of remote monitoring tools that you would ship them to their house ahead of a clinic visit? That would then, I would imagine, not be an acute visit. It would need to be like a scheduled visit. Or do you picture someone going around with a van who's dropping those off? Or how do you picture getting those kind of devices? Because I can't imagine everybody's going to have a connected ultrasound in their home. Butterfly might like that, but probably
yeah.
not.
And by the way, Butterfly is just the company that has this device and tech that's currently available. I don't have any financial interest in the company, just to make that clear. But that's the most challenging part, is that kind of model of how do you get the devices. Lots of people have devices already in their home, which is great. And so how can you use those currently is part of what we're working on right now. And then working with different health systems to sort of get access to devices to folks that already use them, so that it's available in the home when they fall sick. Because we know based on stats, and I have a public health degree also, so people are going to get sick at some point for various conditions. So how can you kind of build it out so they're ready to go in case that happens? And then for the kind of virtual urgent care piece that you mentioned, that's probably the most challenging, is how do you roll that in? And the key is to make sure docs are, understanding limitations of telehealth, and it's not as good as a traditional in-person ER visit, talking to an ER doc. Sometimes you really do need someone in person, and kind of recognizing when that threshold is crossed, I think, is super important.
Yep. I'd love to hear what your thoughts are, since you've thought a lot about this kind of telemedicine space. I feel a little bit like we're in this kind of web 1.0 where everybody's just taking the doctor visit and just putting it on a screen. And we haven't moved to this kind of web 2.0 of social media, the next kind of step beyond that. What do you feel like is what we're going to be doing 5 years in telemedicine is just something we can't even imagine now?
Yeah. Well, I think number one is that I've been using this analogy a lot with people these days, but I think if something positive we can take from COVID, it's that healthcare is being pulled kicking and screaming out of the dark ages. And, like a lot of our colleagues have been forced, because of real genuine safety concerns, to try to figure out how they can connect with patients virtually. And once they do that, a lot of people are sort of scratching their heads going, oh, it works pretty well. Maybe we can kind of integrate. And I don't think that's going to go away even when the pandemic ends. So I think even that alone is a monumental shift in the way people think that, oh, I guess telehealth actually could be an effective way to provide patient care. And then, I don't know, I mean, who knows, 5 years from now, a whole lot could change. I think there'll be a lot. The way that there's a really interesting book I like a lot called Deep Medicine by Eric Topol, and it kind of talks about how you can integrate technology in meaningful ways to stop us as docs from kind of typing all these notes and asking all these questions that could perhaps be automated, and instead refocusing it so that we're actually having a conversation with patients and explaining their diagnosis. And so I hope that I sort of wonder, can technology be used in that way to streamline the whole visit so that we're not doing this kind of automated thing as much anymore, and we're rather taking the time of the visit to talk to the patient.
Yeah. Now, as you mentioned that we may not go necessarily back to normal, before we started this call, we were talking about how our volumes of our ED were so down in both of our institutions. What do you think ED is going to look like in a telemedicine world, given that in the adult side, at least half of patients don't necessarily need to be in the ED in some studies, and in the pediatric world that I live in, it could be up to 80%.
Mm-hmm.
So how do you think this is going to affect what an ED is going to look like in the future?
It's a really good question and complicated, because a lot of what you might think of as patients who maybe don't need to be in the emergency department, I feel like a lot of those could be managed perhaps more effectively by primary care providers who know the patient. And so trying to find better access to a PCP could potentially also be one thing that impacts the emergency department in that way, where perhaps if there's better access through telehealth and through other means, it could decrease that patient volume that maybe didn't have to come to the emergency department in the first place. And then, folks will still come, and there will still not be a clear sense of who does need the ER versus who doesn't. And so maybe in that case, there'll be some sort of way where departments can communicate with patients via telehealth visit as almost like a triaging system. This is something that I've been sort of thinking about and talking about with my own hospital, actually. But, can you somehow link in that way? And then, if they have a primary care provider and they're not acutely unwell, link them back to that PCP. And if you're really not sure, you can bring them into the department, something like that. That's sort of something I've been thinking about a little bit.
Yeah, I've been wondering as well which way it's going to fall. If it's going to be providers that exist now providing telemedicine, or it's going to be third-party companies like yours or Teladoc or Amwell or whoever who goes and takes those patients necessarily away from the provider. Love to hear kind of where you think that's going to fall.
Yeah, well, it's interesting because in Canada, a lot of us ER docs are actually trained in family medicine. And so I have sort of a weird route. I did a year of gen surg, and then I switched into family med, and then am board certified in family and emergency medicine. The Canadian, we're divided by provinces. So I'll just speak to the Ontario provincial system that I'm most familiar with, but we're largely based on a primary care model. And so in my perspective, the best possible care a patient can get is through their, standard primary care provider. So ideally we would link patients who have a PCP back to that person. And our system, Rocket Doctor, is set up in a way that, if you're a family doc that runs an independent practice and you want to start doing telehealth, you can easily use our system. And we can, get you active online to start seeing your patients. And then our key focus is also going to be how to integrate with the EHRs that the different docs use, so that the records, if we do see someone and maybe it's after hours, your practice is closed, we can kind of fit in that way. And then we can get those results back into the patient chart so that they don't get lost and it integrates the care still.
Yeah. And that's one of the things I've been worried about as well, that we already have this especially in the US, a very fragmented system. And then you just add one more vertical layer on that, and it just separates all that data even more.
Yeah.
Well, Bill, I really appreciate you taking the time. We love having you on. I'm super impressed with all the stuff that you're doing, and I look forward to hearing how it all plays out over the next couple of years.
Thanks, man. I appreciate it. Thanks for having me. And thanks everybody who was listening to this.
Yeah. This interview is intended to explore the process of innovation and does not in any way indicate endorsement by Stanford or by our physicians of companies or products being featured.